Hello, everybody. You're very welcome to the Unspeakable Bits. My name is Fergal O'Keefe from MS Ireland. I would like to introduce you to our host tonight, Trevis Gleason, as usual, and our guest tonight, neurologist Dr. Helena Moore. So I would just ask people that if any questions, we can go through them during the night, but just put them into the Q&A rather than into the chat, and I'll be passing them on to Trevis. So please do any questions at all, just ask that. So without further ado, I'll hand over now to my host, Trevis. Best of luck.
Fergal, thanks very much. Hello, everyone. As Fergal said, my name is Trevis Gleason, the host of the Unspeakable Bits, and we welcome you. We would like to thank MS Ireland for their support and for giving us this platform to delve into the topics that were once, and I suppose still often are, considered taboo, but they are a real and an important part of getting over, under, around, and through the challenges of living with this disease. As those of you who have been with us for a few of these now will know, we don't shy away from the difficult topics and questions here on the program. We've talked about MS and sex, relationship difficulties, finances, and so much more, and we're not stopping. So tonight, we'd like to delve into the very real issue that many of us with MS experience, and that's bladder dysfunction. We invite you, as Fergal said, to submit your questions via the questions tab at the bottom of your screen there. Please don't use the chat function. Your questions will be put through to us, and we'll get to as many as possible. Now, it's important to remember that since we have a physician on our panel as our guest tonight, that it wouldn't be appropriate nor really ethical so that we try to answer any direct medical questions. So we're not going to be giving you specific medical advice, but certainly you can ask questions about the condition, and we'll get to those. We are very fortunate to be joined this evening by Dr. Helena Moore, MD, practicing neurology consultant at the Bon Secours Hospital in Tralee. I suppose, as a matter of disclosure, I should say that Dr. Moore is a member of my, I suppose, international MS healthcare team, and so I suppose, Doctor, first off, anything that we've discussed in any of our meetings is open and fair game. My life with MS is pretty much an open book, figuratively and often literally. We're both tucked down here in the southwest corner of Ireland. You're in Tralee and I'm down here in Corcaguina. Perhaps you might start by telling us a little bit about your practice in Kerry, like what's the catchment area from whence you see patients?
So the catchment area is predominantly in Kerry itself. So a population of about 120,000, but then people from North Cork and South Limerick and West Clare would come to Kerry for treatment.
Okay, and I know you're a neurologist that sees a lot of different patients with a lot of different conditions. About how many, or maybe what percentage of your patient population are people who are living with MS?
I would say about 400 people in my practice would have MS.
Okay, that's a fair chunk.
It is, yeah. It's a lot of people.
And of that, and I know we're just guessing here, numbers or percentages, about how many of those do you suppose would experience some form of bladder dysfunction as part of their MS?
I guess it can be up to as high as 50%. So
that's a big number.
Yeah. Mm-hmm.
So Fergal was telling me beforehand that this is this webcast has had the largest pre-subscription of any of them that we have had thus far. So obviously it's a topic that a lot of people are going to want to talk about. And I suppose let's just start out with what types of bladder dysfunction people would come to you and talk about as a neurologist.
Well, predominantly within MS, there are two major types of bladder dysfunction. So there's what I call the irritable bladder, where you've just gone to the loo and you have to go again. Sorry, excuse me. So it's as if your bladder can't hold as much urine as it did before. And then there's the other one, which is where the bladder holds too much urine. You don't get the kind of sensation that you need to go to the loo, and then you get a leakage. So they would be the two principal types of bladder problem you'd see in people who have what's called a neurogenic bladder. That kind of is something that you have to distinguish from people who, for example, could have stress incontinence, which is something that can happen to people for reasons not related to their MS. So, for example, in women who've had babies, they can have a weak pelvic floor. It's the kind of incontinence people get when they laugh or sneeze. So certainly some of that can be MS related, but there are other things that cause bladder trouble.
And I suppose it goes back to something that one of my MS care providers once said to me when I asked, well, is it MS or is it something else? And the answer was, well, does it really matter? If it's a symptom that's bothering you, we need to take care of it. So in those cases, whether it is MS or something else, there are ways that we can treat a lot of this. Is that correct?
Yes, but I think it depends on what the cause of it is. So, for example, if it's a gynecological issue, then you need to channel the patient to your gynecologist, for example. Whereas if it's related to the MS, then as you say, we need to sort that out. Like bladder problems cause a lot of people a lot of concern. And it's interesting that we're having this chat tonight about it, because increasingly even the ads on television for incontinence are bringing this subject out for public airing. And we realize a lot of people have issues like this.
Well, I'm seeing a question that's come up already. I wear incontinence wear every day. I can't seem to hold my urine. What I do, we'll get to some questions, but incontinence wear right there. I've just been back in America, as I mentioned, with a book tour, and my God, when you watch the television there, it's like every third advert is for prescription medications. And certainly bladder incontinence drugs are one of them. I don't know if you can gauge how common a symptom is by how often you see an advert for it on television, but if it is any gauge, there's a lot of people, and obviously a lot more people than just people with MS that have them. But we won't get into prescription medication adverts there. Let's just a little bit about the mechanics, I guess. And when I talk about the mechanics, I respect the fact that we're talking to a neurologist, not a urologist, but as an MS specialist, I think it's important to start here. We can all somehow get our heads around the central nervous system symptoms. It might be easier for us to think about our legs problems or our vision, or maybe even fatigue by stretching as a direct result of some issue in our brain or spinal cord. How is it that the bladder and the excretory system somehow get caught in this web? I mean, it seems like that's an organ issue, not neurology. So could you explain that one a bit for us?
Well, the bladder is innervated. So nerve endings come from your spinal cord into your bladder. And that tells it, for example, it's how the message goes back to you that your bladder is full. So if you have spinal MS, then there is a possibility that you will interrupt those pathways from your spine to the nerves to your bladder. And of course, nothing is simple in neurology, because you also have areas in your brain which are very important for controlling bladder function. So, for example, there's what's called the pontine micturition center, micturition being the medical term for passing urine. So that's a control center that's in the part of your brain that connects the cortex, which is the thinking part of your brain, down to the spinal cord to send messages down into your bladder. So if you have an MS plaque in that region, you can interrupt the function of that area. And then, of course, if we go further up into our brain, so into what is called your frontal cortex, where some people can wet themselves if they get a fright. Well, again, MS plaques can interfere with how that part of the brain works. And so you can have, if you like, involuntary wetting of yourself, which is part of your MS. So all of the pathways that innervate your bladder, it all tracks back up towards through your spinal cord into your brain, and the other way around. So at any point in that long pathway, you can have interference with function.
So the part of your brain that you were talking about there, I think people who have ever gone through a sleep study because of sleep apnea might realize that that's the part of the brain that keeps waking them up at night to telling them they have to pee. and they go to urinate, and there's not really anything there, but it's that part of the brain that's been activated saying, hey, you're not breathing. So am I correct in that?
And it's a bit higher up, but somewhere close to that. Yeah.
Something along that line. Wow. So a quick summary for everyone. I suppose the bladder issues can, I used to say that the world can be divided into two kinds of people who divide the world into two kinds of people and people who don't. But bladder dysfunction pretty much can be either the inability to store urine or the inability to fully evacuate it from the bladder. That's a fair analysis for us to start.
Yeah.
There.
Yeah.
Okay.
I think that's a good place to start.
And the comments that are coming in, as well as some of that came in before, this is a quality of life issue. If we're always looking for the loo when we go out, like a firefighter looks for exits in a building when he goes in, or worse, if we're not going out and missing out on social functionality because of our bladders, we're really living less of a life than we deserve. So how does the quality of life conversation happen when you're talking with your patients about bladder dysfunction?
It's mapping what the bladder dysfunction has done to their lives. So, for example, there are some people who will only wear dark clothes in case they have an accident. Or there will be people, as you say, map their journeys by the toilets, or, see toilet, will go, mightn't think they might need to pee, but there's a toilet there, I will go. And then the other thing that is often very concerning is because they're trying to control how likely they are to have to go to the loo when they're out and about, they reduce their drinking. And so they don't drink enough fluid. And then that causes another cycle of problems, because if you're not flushing through your bladder, that increases the risk of you having an infection. It also increases the risk of you developing kidney stones. So in addition to all the social restrictions, you're also potentially lining up medical complications for yourself as well.
Yeah, it can get pretty serious, and I want to get into that a little bit further. But for some people, it's annoying. We've got a comment right here. It says, I have a dose of my bladder leaks every time I cough. It's annoying. I'm from Tipperary, but some of these things can be annoying nuisances. Little niggles in the back of the brain is looking for the loo, etc. But we can get pretty serious. There's someone who's talking about that they had their prostate removed, which is leading to bladder issues as it normally would. But he's wondering if, and I'm assuming it's a he because it's a prostate issue, but he's wondering if MS could complicate his recovery from that when it comes to abdominal floor muscle exercises and that kind of carrying. Is it possible that this might be another layer, even though the removal of the prostate was what really caused it in the first place?
I guess things are multiplicative as opposed to adding on. So if you're starting off with an MS bladder, and then you have your prostate removed, and what happens is that the nerve endings that control bladder function can be potentially damaged when you have your prostate removed. Then you have a double whack. So a bladder that was irritable before your prostate was taken out may be worse now.
And would the same be a case if a woman had children and was experiencing some of those things, and then perhaps was diagnosed with MS, or vice versa, that one could exacerbate the other?
Well, it's yes, because you have more than one problem. You have more than one pathology happening. So in the person who has a weak pelvic floor because of childbirth or whatever, there are other causes. It could, for example, if you had a hysterectomy, or then with men, if they have prostate trouble, there are other pathologies which add into the MS.
Okay. Now, I want to make sure that everyone is encouraged to write in their questions. I won't be putting any names to them or anything, so don't fear that. You can these are things that we can ask anonymously because they are, well, unspeakable. So please put those questions into the Q&A section. We'll get to as many as possible. Many, if not most of us, Dr. Moore, MS or not, would have experienced a UTI, a urinary tract infection. While it might matter necessarily for initial treatment, whether it was MS or otherwise that caused it, it's important for our MS team to know about them when they occur. I guess what I'm asking is, we get the symptoms of a UTI, you know, the frequency, the burning, those kinds of things. Who should we go to first? Should we call the GP? Should we call the urologist if we've got one? An MS nurse, a consultant such as yourself? I mean, it's a UTI. We know that first. Who do we go to?
Well, if you have a symptoms of a urinary tract infection, then it's your GP is your first port of call. And again, it's like all of these things, and a lot of my patients will recognize this mantra. Just because you have MS doesn't mean that it's the MS that's causing the problem. Certainly people who have MS or with certain types of MS would be at increased risk of having urinary tract infection. So when a man has a urinary tract infection, that's a signal that there's something wrong, so it needs to be checked out. Because men don't usually get urinary tract infections because the urethra, which is the tube that leads from the bladder to the outside, is longer in men. So there's a longer distance for bugs to travel up. And so it's not something that you would expect to see in a man who is, inverted commas, healthy. Women, we have a shorter urethra, so we're at greater risk of having urinary tract infections. So they don't tend to ring the alarm bells that they would ring in a man. But nonetheless, if you have the symptoms of a urinary tract infection, which are, pain or difficulty passing urine, sometimes you can see some blood in it, sometimes you can have a fever or chills, you should see your GP. Then if you have an MS nurse, let them know you've had a urinary tract infection. A bit like one swallow doesn't make a summer, or in West Kerry at the moment, thousands of swallows don't make a summer, that you need to be aware of it, but don't panic. And then if you're having recurrent urinary tract infections, then we need to check things out. Again, they don't always mean it's related to your MS. So for example, if you had a bladder stone, which I suppose is related to your MS, but that could increase your risk of having kidney infections or urinary tract infections. But probably what's more concerning in the group of patients who have MS is that sometimes they don't get the signals that they're having a urinary tract infection. Because, for example, the sensation isn't as, if they've spinal MS, they may not have the same sensation of pain. It may be actually their MS that signals to them that they have a problem with their bladder because their spasticity increases, or their mobility reduces, or they might find that they're more tired than usual. And those are signals to check your urine and see if there is an infection, versus, if you like, the non-MS population who may get the symptoms that we associate with the urinary tract infection. But first port of call is your GP.
Please.
Sorry, first port of call is your GP, and then if it becomes a pattern, then it's to either your urologist if you have one, or to your neurologist, who will probably divert you to a urologist.
And is that a fairly common conversation that you would have with someone who has had recurring urinary issues because of their MS, that you would send them on, and then you would work on the professional level while they worked at the patient level with that urologist? Yes,
I would ask the urologist to see them, because again, you need to visualize the urinary tract. You need to make sure, for example, that if it's a person who has had that bladder that doesn't empty properly, there may be a backflow of urine up into the kidney, which could cause the kidney to dilate, and so that may need to be decompressed. Now, we're talking the most dramatic things, so that people who are listening, these are the exceptions, not the rules, but this is why we do tests, because you want to make sure that if someone's urinary system is under pressure, that we look after it. Equally, if you see the urologist, they will generally do an ultrasound of your pelvis, looking at your bladder, looking at your kidneys. They may do a thing called a CT-KUB, which is where they look again at the drainage system of your bladder, look to see if they can see any stones in your kidneys, or stones in your tubes that lead from your kidneys to your bladder, which are called your ureters. and see if there's anything there, and then almost always they look into your bladder as well to see if there's evidence of abnormalities in the bladder itself. So these are the things the urologist will do, and then may decide on intervention if necessary.
So you were talking about visualizing the urinary system. You talked about ultrasound. Is CT part of that? We wouldn't do an MRI on that, I suppose. A cystoscope. I mean, these are starting to get kind of scary when we're talking about some of that.
Well, an ultrasound is a non-invasive procedure, and that's easy. CT scans, we don't like to do them too often because they do have radiation, but very little radiation. So a lot of times it'll be done as an initial investigation. Cystoscopy is less of a big deal than it used to be. Like a lot of the time now, it's done with very minor sedation or just local anesthetic, where a very fine tube is passed up into the bladder and people look at your bladder. So it's not any really more invasive than having a gastroscopy, for example.
Okay, all right. And as I said, my life with MS is an open book. You had mentioned that it's just because you have MS, it's not always MS. And a number of years ago now, I had recurring UTIs, and my GP had me on more and more courses of antibiotics, and it just seemed like as soon as one course was gone, then I'd have another one. And I just thought it was MS, I was just having bladder issues with MS. But then eventually I ended up passing wind with my urine, and we ended up finding that it was actually a colovascular fistula, which was a significant issue. We ended up 8 hours of surgery during the COVID days and all that. So folks, if you are having recurring urinary issues, it mayn't necessarily be your MS. It may indeed, but something certainly that should be investigated. Now, you were talking about how serious some of this stuff can come. Our urinary tract can be affected by so many things. So the importance of vigilance, and we're afraid to cry wolf sometimes, but some of this stuff can be pretty serious when it comes to our urinary health. How do we know when it's going beyond that, particularly if we've got some of the sensory deprivation that you were talking about?
Well, again, patients know their bodies, and so that's why if you have a sudden, inverted commas, change in your MS, like someone who has been very stable and then says, "Oh, I'm having spasms in my legs. I haven't had those for years." You need to think, is there something else wrong? So, for example, have you developed constipation? Have you got a chest infection? Have you got a urinary tract infection? Were you at the chiropodist and have, cut your toenails in a funny way? And because all of these send different messages into your MS that can make your MS active. It's not a real relapse, a pseudo relapse, or not even that, just that the symptoms are more active. So when that happens, then you should think to yourself, a tick box. And if your urine can be dipsticked, your chemist can do that for you, your practice nurse can do it. And if it shows evidence to suggest there's a kidney infection, the sample can be sent to the lab, and a result can come back from it. So they're the kind of things that you can do for yourself. I think it is very important to be aware of it. And the other thing too, though, is not every urinary symptom is an infection. And so you want to not be on antibiotics all the time, because that's not good for you. Also, it can encourage resistance. So sometimes we will say you need to have more than 100 white cells in your urine before we get excited that it might be a urinary tract infection. Or your GP may say to you, actually, there was a mixed growth on that urine. We need to repeat it, because sometimes you can have contamination from bacteria that aren't causing infection but are living in your perineum. So all of these things need to be taken into account.
And I suppose to bring the point home as finely as possible, an undetected or an untreated UTI can become something much more serious. You talked about dilation of the kidneys, etc. I've known far too many friends of mine with MS who have significant issues with MS, particularly below the waist, etc. And they've ended up for long hospital stays because these turned into kidney infections and they went septic. For some people, a UTI is an annoyance, and you grab some cranberry juice and you go on antibiotics or whatever. But for those of us with MS, it can be far more than that. It's frightening to think about, to talk about, and a lot of the comments that we've got, the questions coming in, have to do with some of the annoyances. But it's something that's beyond annoyance sometimes, and we need to take it seriously. Is that correct?
It is correct, and what you don't want to have, or what you wish to avoid, is people developing kidney stones if you can at all. If you don't want, for example, somebody to have a toxic megaureter where the ureter just dilates up because it's not able to, the bladder isn't emptying, so the urine is backed up. So that's why we do all the tests one does when one presents with a urinary symptom, because you want to find out what's happening.
And we've got a question that came in via email before we started the program. This person is doing the same thing as far as fluid intake and exercise and all of that, but from day to day, it seems that she may have spastic bladder one day, and the next day it seems fine, and she's peeing a quarter of the number of times. Is that common? Is that seem like fairly textbook, or is that something a little odd?
That's unusual, and that's why people do urodynamics, because what you're trying to figure out is whether the person has the spastic irritable bladder or whether the person has the overflow bladder, and urodynamics tend to tell you that. But I've learned as a doctor, what the textbooks say and what the patients say are totally different.
Right.
So, the theory is you either have a floppy, saggy bladder, inverted commas, or you have a tight spastic bladder, but that's not how patients present. And sometimes that's where, and I'm sure we'll move on to it, where sometimes you have to look at more invasive ways of managing your bladder than just, for example, drugs that can help with a bladder that is very baggy. Sometimes there are drugs that will tighten it up. Anticholinergic drugs may help. But if you have somebody who has that kind of bladder, that when a drop of urine hits what's called the trigone, which is, if you like, this like a falls mat, it's your sensory thing to tell you there's urine there, and they get that feeling they have to run to the loo, and off they go to the loo and there's nothing. That's very irritating, because obviously when you hear the signal, or we train our bodies that when you get the signal you have to go to the loo, that you go, because you don't want to wet yourself. So you get the signal, nothing happens. The next time you might ignore it, and the next time you flood. So it's very frustrating.
There's a question from an anonymous attendee asking specifically that. She'll get up several times during the night, or he, and not really have to go. The bladder isn't full. That sounds like it could be something along that line. How do you treat that?
It's challenging to treat something like that. Like if it's somebody has a spastic bladder, then catheterisation doesn't always help. So sometimes you look at having something like Botox, which relaxes the bladder. Sometimes we try medication, though it has to be said the medications tend to work better for the bladder that's in a bit of overflow or not contracting enough than for the person who has the spastic bladder.
Okay. There's another question. Someone's on antibiotics currently, and their bladder issues seem to be worse right now. The GP doesn't seem to be concerned. Is that a typical reaction? It's a sinusitis that she's on antibiotics for. So is that odd?
I don't. Well, you see, it may be that it's what we're talking about with having something else wrong with you can cause your MS to get worse. So if you have sinusitis, it's like having a chest infection. it may cause a vulnerable part of your MS to become more irritated.
All right. That makes a lot
So
of
if
sense.
your bladder is the bit that kind of is, it's a bit like your poker tell. If your bladder is your tell, that's the thing that causes you most problems with your MS. Then if you have a chest infection, sinus infection, if you're stressed from anything, then your bladder will cause mischief. Whereas
Okay.
if your tell is your spasticity, and that, you know, suddenly your legs start kicking against you, then that's the thing that's going to tell you something's wrong.
So it sounds to me a little bit like, I know for the aged population, if they start acting a little odd or forgetful more, the first thing is take your temperature, see if it's elevated. It's probably a UTI that you're not aware of, and that's causing an elevated temperature. Certainly, we know that raised body temperature can cause that pseudo exacerbation. So that's sort of what you're talking about there, that something else is affecting the body's temperature, for example, and you're getting a pseudo exacerbation. And I really like that term, the tell. If that's your tell, something's going to affect it.
Yeah. No, exactly. That's it.
We've got one question in reference to medications, and we'll get into that a little bit further, I'm sure. But this person is worried about the side effects of medication, et cetera, and adding another medication to the you know, the arsenal of tablets they're already taking. You seemed pretty quick and emphatic about that. So can you talk about some of those worrying side effects?
Well, with drugs which are called anticholinergic drugs, which are predominantly the drugs that we use to try and help bladder dysfunction, they can cross what's called the blood-brain barrier, and so can cause confusion in people who are vulnerable. So if you're somebody with MS who has some cognitive issues, and you take an anticholinergic drug, you may find your cognition gets a bit worse. So you might notice your memory is a bit worse. So it's not the drug for you. Now, it's unlikely your MSologist or MSologist particularly, if we know that you have some cognitive issues, are unlikely to prescribe an anticholinergic. But some of them are very good. And in younger people who don't have significant cognitive issues, they may very well help. They can cause dry mouth, they can cause constipation. So already in someone who's inclined to be constipated because you have, or may be inclined to be constipated because you have MS, another drug into that mix doesn't help. They can also, in an age group of a man who has, you know, is entering that age group where prostate can cause trouble, if suddenly been on an anticholinergic can cause you to go into urinary retention. And if you're a person who has had a history of glaucoma, you would tend to be cautious using an anticholinergic. But as always, this is what a doctor does to a patient. You raise the red flags and say, these are the bad things that can happen. But you have other people where this works really well and it doesn't cause an issue. There's also a drug, the generic name has gone out of my head now, but Betmiga, which works in a totally different way, which doesn't cross the blood-brain barrier and is less likely to cause those cognitive effects. And equally, the because it's not an anticholinergic, it's not going to cause prostate issues or glaucoma. So there's choices. So it's like always, you know, you can't just treat a symptom, you have to treat the person. And see what else is happening in the world when you're making choices about medication.
And for someone who's having that retention problem, does a diuretic work?
Not usually, no. If you're into retention and you're not emptying your bladder properly, you're probably looking at catheterization, self-catheterization. And you know, if you can imagine, like your urinary tract is a plumbing system, and if you're not able to relax your sphincter enough to let your urine flow out, which is what happens with people who have prostate trouble and they go into retention, they're just not, the opening is not wide enough anymore, and that causes the mischief. In patients with MS, the problem is that the nerve endings that either release that aren't working properly, or that the bladder itself, the nerve endings into the bladder itself or from the brain aren't working. And so then catheterization can be the answer. Like I remember giving a talk a long time ago at an MS meeting where, again, we were talking about urinary symptoms, and one patient in the audience stood up and said, I wish someone had talked to me about intermittent self-catheterization a lot earlier. It made such a difference to the quality of life. Like it is, you know, it's a very awesome thing to have to face into. And you think you'll never get the swing of it or the manage it yourself. But if you do, it gives great freedom. And it's important that you're trained how to do it properly. Like we're very lucky here. We have Cara. Cara will help people learn how to do it, but there are urology nurses and catheterization nurses in all of the hospitals that feed into this region.
There's a good few questions coming through about different disease-modifying therapies and if they can somehow make a person more prone to UTIs. A number of people seem to be mentioning different meds and saying, am I getting more UTIs because I'm on this med? Or is it just that they're getting more UTIs in spite of being on the med?
Well, as you know, a lot of the more sophisticated drugs that we use for MS now are immune modifiers. So as a consequence of that, they increase your risk of infection. But it's a combination of things in that how the MS is affecting your body is making you more vulnerable. And then you have this drug that decreases how your immune response is. So the two things combine. So if you're somebody who was at increased risk of urinary tract infection before you went on, say, for example, a CD20 inhibitor, you probably will have more urinary tract infections. So that being said, in my patient cohort, we haven't noticed a huge increase in infection. So I don't think I would attribute it simply to the drug. I would say you maybe have been more vulnerable to getting them anyway.
And, you know, perhaps I jumped in too quickly into the concept of a UTI, but one of the questions is, what's the difference between a urinary tract infection and a kidney infection?
A kidney infection really is a colloquialism. It's something that people use to describe it. That a urinary tract infection refers to there's an infection in the urinary tract, and it's for example, the proper name for a kidney infection is pyelonephritis, which thankfully we rarely see. Like that's a very significant infection, and it's localized in the kidney itself. Whereas what we're talking about is an infection in the urine. So maybe semantics, but you know, in everyday language, it's a kidney infection in the way that, for example, a chest infection is technically either an upper or lower respiratory tract infection.
Understood. All right. Thank you for that. One final question from the group, and they're coming in fast and furious, and please do keep putting them in there. We'll get to as many as possible. The thought of cognitive issues on some of the bladder drugs. How can we tell? Is it? I mean, if we're going on one of these, should we get a neuropsych eval and for a baseline and go from there, or is it just should we see if we're forgetting more? I mean, it's a justifiable question.
I know I'm smiling because getting a neurocog assessment is challenging. Access to them is not easy. So, like generally, it's something that you warn patients about. So this isn't unique to MS. So, for example, we would have patients with Parkinson's disease where we would use anticholinergic drugs, and the first thing you say to them is, you know, if you notice or your family notice that your memory isn't as good as it was before, think the drug, stop the drug, and then see if you come back to your baseline. So, you know, it generally declares itself quite easily if that's what the problem is.
And is there any long-term effect of these
No,
medications making them through the blood-brain barrier?
no, there not at all. And it's something that I suppose we're increasingly or maybe more alert to in the Parkinson's world, because sometimes we use these drugs for treating the tremor, and so we would be saying it to patients um, and are very aware that if anything changes, we'll stop it. Whereas in with our MS patients, because thankfully all of the disease modifying drugs are so much better and patients are so much better themselves, that we're now seeing more cognitive issues in MS that maybe we weren't as aware of before. And so now have to tune into the fact that some of the medications we can give people can make those a bit worse, but it's not causing the problem, it's not generating the problem, it's just accentuating it. So pull out the drug and you'll go back to baseline.
And this is another time that it's really important to kind of get those closest to us involved. I know for my cognition, my wife and I play a weekly game of gin rummy, and because numbers can be a thing for me, and she's able to kind of gauge where I am and how I am. And certainly if we're going to the toilet more often, we might just sort of get used to it in our heads, but someone could kind of keep an eye on us. So someone close to us that knows what our baseline is, and could kind of keep an eye on that, certainly in this instance, cognitive, that's good, that's important. Now, beyond the UTIs, and into more marked dysfunction, I suppose, some of the stuff you started to talk about there can be scary to people with MS, like self-catheterization or long-term Foley caths, or surgically implanted catheters, Botox injections you mentioned. We're getting to some of those unspeakable things, but some of these symptoms can be attended to with prescription medication. Some can't. Some can be, the GP can handle them. Some of the neurologists, you might need the specialist. When do we know that it's time to elevate, or do we rely on our medical professionals to say, okay, it's time for you to see a urologist about this?
Well, to see the urologist, generally, if you're having frequent urinary symptoms, you haven't responded to the medication that maybe your GP would try. So, for example, there are patches that sometimes we use. There are a couple of other medications and they don't work. Then it's time to see your hard to say, your urologist, and then kind of define exactly what this medical problem is. So are you an overflower or are you a small spastic bladder? And then that determines what you do next. And then equally, like I can remember one patient vividly who was having problems with, when we did his urodynamics, he was retaining urine, he wasn't emptying his bladder properly, he was having a residual volume of about 500 mils, which is way too much. We taught him how to do intermittent self-catheterization, and he was unlucky enough to get an infection. He hasn't gone near a catheter since, and 10 years later, he's doing okay. Why is he doing okay? Because he's being very vigilant about drinking plenty, and if ever he gets anything that he thinks might be urinary tract infection, he's straight to his doctor. But he's the exception. Patients who have large residual volumes, what happens is that urine stays stagnant in your bladder. It is a lovely place for bugs to come and grow, and then you run the risk of having a very significant urine infection. You run the risk because you're not emptying your bladder of urine. You irritate the wall of your bladder. You start generating extra mucus in your bladder. The next thing you have the little kind of formation of a stone, a bit like when they put something into the oyster to irritate it to make a pearl, except it's not a pearl. It's a bladder stone or a urinary tract stone. And like any of you who are listening who've had a kidney stone, they're not pleasant. And so you need to avoid them. So at that point, you've had your urodynamics done. It's saying actually there's nothing left in your bladder, so you're this person with the small spastic irritating bladder, or it's saying to you, actually, you know, you've just gone to the loo and you still have 500 mils left. You're somebody that needs to do something to empty your bladder. And that decision is made, you know, you as the person who has the problem is kind of the captain of the ship. The person, like your urology nurse, your neurologist, urologist, all we can do is give advice. And then sometimes patients go weigh and measure it and come back. Or sometimes patients have had enough of it and say, right, I want to try intermittent self-catheterization. And obviously, one of the rate limiting things with that is the dexterity of your hands. So some of our patients with MS will have hands that are maybe shaky, or hands that on good days work and on other days don't work. And so that might catapult the decision from trying intermittent self-catheterization into actually considering a suprapubic catheter. And
So
that's a
can
big
you
step.
maybe talk a little bit about those, because that's sort of that step beyond self-catheterization. That's literally inserting a catheter through the urethra into the bladder and draining it on a regular basis, I'm suspecting.
Yeah.
That sounds awful to a lot of people, but so does using a walking aid. Sometimes it's a hurdle to get over, and we don't realize that we're keeping ourselves from getting out into the world because we need something to walk with, and we're embarrassed about that, or we just don't want to go over into that place. The same with catheterization. I mean, it might seem like a terrible thing until you start doing it and realizing, oh my, I can do so much more. It's a quality of life issue. But then we get into someone had mentioned it sounded like a condom type of catheter that they put on that's got a tube coming off that as well. Obviously, probably wouldn't work for women, but then also to the suprapubic, the surgically implanted ones. Can you tell us a little bit about those?
So the surgically implanted catheter, generally, we consider it when somebody has evidence of just not emptying their bladder properly, and so we're running into trouble with recurrent significant urinary tract infections. And a suprapubic catheter is a tube that is passed directly into your bladder through your tummy. It can be done, some places will do it in the radiology department, but most people it's done in theatre by the urologist. And like it's a significant thing for a person, because I suppose it's a violation is too strong a word, but people perceive it as that, because now you have something coming out of your body. It's not, your body's no longer, inverted commas, intact. There's a tube that somebody has put in there, and people can have huge conceptual difficulty with that, and understandably so. And then, of course, you know, you'll always have the worst stories out there. You know, the tube went in, oh my God, it was agony, it fell out. I was barely outside the front door of the hospital and it came out and there was blood. And there's a lot of bad stories. And it's like everything. Most people don't post the good story. Most people don't say, yeah, I have the tube in, it's changed by the community team every 8 weeks. And it has changed my world, because now I don't have to worry about having a leakage when I'm out and about. I can go out with a small leg bag. I can go into the loo, empty it, and continue on with my day's work. Or at night, I'm not getting up to go to the loo every 5 minutes, because at night I've put on a big drainage bag and I don't have to worry about it. Of course, that's describing the ideal, where it, you know, works perfectly. And I'm sure lots of people listening are saying, yeah, well, I had the tube in, and, you know, yes, it drained into the bag, but I still wet myself because it was bypassing. And so that some of the urine was still coming out through the urethra as opposed to going directly into the tube. That can happen. Sometimes it's different things. The size of the tube you put into the bladder may not be the right size for you. Sometimes there's a patient factor in that they're still not drinking enough because they were so used to not drinking that they aren't into the swing of it, and so that kind of mucousy stuff that I was telling you about gathers around it and blocks the drainage system of the catheter. So different things happen, and it can be challenging. You know, the urology nurse and the urologist are coming up with different things to try and make this work. But for the vast majority of people, a suprapubic catheter does work. And it does give great freedom, and it also gives great freedom for the carer. If you have somebody with you who is doing their best to make sure to help you get to the loo on time, but you don't get there on time and there's an accident and there's a load of cleaning up to be done, and then it takes away that carer burden. Or if at night, while you're quite reasonably independent, but you might need a hoof up out of the bed, your partner isn't getting a full night's sleep, that translates into crankiness the next day in spite of their best efforts. So, you know, sometimes having a suprapubic catheter put in is caring for the carer.
Mm-hmm. It is, I suppose it's one of the fears that we have, if you start needing something, you're always going to need it. That's it with any aid. Is a suprapubic catheter a one-way street?
It tends to be. It tends to be, once you get to that point, you've generally exhausted the other avenues. Mm-hmm. Usually, but as I said to you earlier, there's exceptions to every rule, and so there are exceptions where it is taken out, or it can be taken out, and the tract heals up very quickly, and sometimes, you know, the cure can be worse than the disease. Like for some people, the psychology of it just is too much, and they would rather manage with incontinence or as you mentioned earlier, a condom catheter rather than the invasiveness of it. Mm-hmm. But I would hope, and I'd say I reflect most urologists and neurologists, we generally tend to have done all of the non-invasive stuff first. You try to go down that pathway before you go to the suprapubic.
And it's probably not a one-way street, but for a lot of people who have seen Hollywood stars and starlets with foreheads that don't move anymore, the concept of Botox injections into the bladder, for someone who is experiencing incontinence, it seems like that's the worst possible thing because it's just going to make it not hold anything at all. But how does Botox injection into the bladder work, and for whom does it work?
What it does is relaxes the bladder in some patients, or relaxes the bladder muscle, because what Botox is effectively a muscle relaxant. But then the irony of it is that on occasion the bladder then can go into spasm, and you may actually need to have a catheter for a little while afterwards. So, like anybody who has had Botox for their bladder, your urologist will say this to you: there is the risk that you will go into retention and that you may need a catheter, but it's usually only for a few days while your bladder settles down.
And would this be a Foley cath, one that goes in and kind of holds there through the ureter for a while? Anybody who's had some surgeries will know that one.
Yeah, like exactly. It's the one that's similar to if you've been very unwell and your urine needs to be monitored on a regular basis, or if somebody had a prostatic problem and they went into retention. It's the same principle, and it's only temporary. So that's the.
Sorry to cut across. Non-medical, things that we can do. You talked about bladder floor. I mean, our Kegel exercises. Something that's good is keeping our urine acidified with cranberry pills or something. What are some of the complementary things?
Well, I don't think there's a huge science behind poor old cranberry, and certainly avoid the cranberry juice because there's loads of calories in it.
Sugar.
So the cranberry tablets maybe. Like the big things are counterintuitive if you have incontinence problems. It's like keep your bladder flushed. Don't don't run yourself dry. Now, some people will run themselves dry because they're going out and about, and they'll say, well, I'm not going to drink while I'm going into town to do the shopping at Tesco, but I'll drink when I come home. Equally, the opposite. It seems to me that it's a new appendage that people have, is this sucky bottle that everyone seems to carry around with them. Like, there's no huge need to be drinking 4 litres of water a day either. So it's a happy medium in everything. Avoid constipation, because if you think about it, your bowel and your bladder sit in the same space. So if you're constipated and there's a lot of stool in your rectum and in your lower bowel, there isn't room for your bladder to hold urine. So you need to keep your bowel moving regularly. Pelvic floor exercises, generally keeping yourself fit. As you know, like, there's been a huge push now in chronic neurological conditions that we want you to keep what you've got. So you need to keep yourself exercised. You know, if you've done fatigue on this podcast before, it's frustrating when the doctor tells you exercise to combat fatigue, but that's what we're trying to do. We're trying to get you to make your body more resilient with this chronic illness. So, yeah.
Sorry, things are going at pace tonight, and I just got a note from Fergal, our producer, saying that this is the most questions that we've had asked during a session ever, and it's because it's an important topic, certainly. I suspect that we might be needing another one of these at some point.
An overflow.
Yeah. Well played, overflow. I do want to give you a moment or two, Howard, just to kind of wrap up any final thoughts that you have about bladder dysfunction. And by the way, I wrote a piece recently referring to something that you had talked about at a seminar I was at recently, and when we talked about cog fog, you'd said it's time that we stop using that term. It's cognitive dysfunction, and I like the term because it makes it more, I don't know, medically real and something that needs a concern. Certainly, bladder dysfunction. These are dysfunctionalities of the bladder, and I thank you for talking about it. Any final thoughts that you'd like to leave everyone with here?
I think it is important to discuss it. Irish people tend to be still quite prudish about things like this, and won't necessarily bring it up in conversation. Equally, when your doctor says, is everything okay, they may not necessarily say, and how's your bladder, or how's your bowel? So, you know, come in there with it at that point. I think you and I have talked about it before. When you come to see the neurologist or urologist or whoever your doctor is, like, you are often in a position where, as a doctor, you have 5 minutes to spend with this person. So you need to come with it, be ready. Have your story, have your questions, a bit like tonight, the way people have been asking questions. And then it is important, if a person is having recurrent infections, that the GP sends them to see a urologist, or I, as the neurologist, will send them to see it, because we need to characterize what's wrong. We need to find out if you're the saggy bladder or the spastic bladder. And then, as I say, we also need to be aware that it may not simply be MS. There may be something else wrong. So in a particular age group, we don't want to, for example, miss uterine prolapse, which can cause all sorts of bladder problems. And then in the patients who are men, if you're looking at a prostate problem. So you need to evaluate everything. And I suppose for the patient not to accept that it is, oh, it's just your MS. No, I want it checked.
Very good. And there were so many questions that we couldn't get to, and many of them came in anonymously, and that tells me that they're not asking those questions of their GP or their neurologist, etc. I want to extend to you my greatest thanks, Dr. Moore. Please know that you've made a difference in an awful lot of lives here, and to hundreds of people who will be watching this over the coming weeks, as they always do. So many thanks. And for all of you who are listening and watching, don't forget to mark your diaries for our next Unspeakable Bits episode. That's the Thursday, the 18th of July, when we'll talk with a panel of experts about a difficult topic again. What if I can no longer work because of my multiple sclerosis. Until then, I'm Trevis Gleason, wishing you and your family the best of health. Cheers, and back to you, Fergal.
Yeah, so first of all, Dr. Moore, I want to thank you for tonight, and of course, Trevis, as usual, for being a great host. That was an amazing conversation. And just let people know, an awful lot of people wanted to be here tonight that actually, couldn't. So we will be putting it up on our YouTube channel next week, and we will also be putting up the registration next week for the next Unspeakable Bits. So just keep an eye on our social media channels. So thanks again, Helena and Trevis, for a great talk tonight, and take care.
Good
Cheers.
night.
Bye.